So is there a sign that I need to wait for to start, or do we just go ahead and start?
We're just going to give it another minute for people to jump on. I've seen a couple people join, so why don't we give it just about a minute or so, and then we can proceed.
Right, just let me know. That's fine.
Okay.
Yeah.
All right, the time is 6 p.m. I think we should just jump right in.
All right, well, welcome everyone, and thank you for coming to our webinar, which will be hosted by Dr. Brooke Rosheim, a colleague of mine who we are veterans of the last 3 years, the COVID epidemic, and we look forward to the discussion. Brooke works at the Virginia Department of Health, and I will give the description as he wrote it. So, which is that the webinar will cover an overview of the current monkeypox situation, and now it's known as MPOX, epidemiology of the virus, risk assessment and communication, infection prevention and control, testing collaboration with public health officials, and medical countermeasure strategies, including vaccine and treatment options. There will also be allotted time for questions. So with that, I look forward to Dr. Rosheim's discussion. Brooke?
Okay, well, thank you, Stuart. I appreciate it. And I want to thank you and the Virginia chapter of the American College of Physicians for having me. And so we will go ahead and start talking about monkeypox or MPOX. I'm going to go ahead and share my screen. And so the slides will be coming up here in a minute. So you should be able to see the slides in the sort of the small version right now. And let's go to the presentation mode. Let's see. Hold a second. Okay. And now can you see the slides in their large form? Okay, great. Okay. So basically, here is the outline of what we're going to talk about. I've got sort of 6 big topic areas. First, a general monkeypox overview. And as Dr. Hanakowitz said, the WHO has now changed the name to MPOX, and so that is synonymous with monkeypox. MPOX clinical assessment and evaluation, MPOX infection prevention and control for healthcare settings and also for non-healthcare settings. MPOX testing, monkeypox vaccination, MPOX treatment and patient management. There are a lot of links in the slide deck. The slide deck should be sent out. If you don't already have it, it will be sent out. The links are all live in the slide deck. These are 2 high-yield resources for clinicians. One is a CDC page, and then one is the VDH monkeypox healthcare provider webpage. So let's start out with the overview of MPOX. As we've already talked about, the new terminology, which actually takes effect over the next year, is MPOX. This is a multinational outbreak. There was a recent MMWR, actually, it was done a number of months ago, that looked at the epidemiology of cases of MPOX. 99% of them, this is US data, 99% of cases were in men, about 94% of whom reported recent intimate or sexual contact with other men. And very importantly, about 40% had concurrent HIV infection. As of yesterday, so this is data from the US, there have been 20 fatal cases of MPOX in the US. And if you look wide, as of yesterday, 82,550 cases globally from 110 countries. The US has a total of 29,643 cases. The US is by far the #1 country with MPOX cases. So let's look at MPOX data in Virginia. So what we have is our epidemic here. And you can see that we reached, you can see with the mouse that I'm pointing to the top of the epi curve. These are weekly case numbers. And we hit our weekly peak at about the middle of August of 2022. Since then, you see a very nice drop off in the number of cases going, down and down and down. And now we are down to, in the single digits of cases per week. And that is really very good. So if you look at Virginia's data, as of yesterday, 562 confirmed cases. There have been 25 patients hospitalized. There has been 1 death. 94% of the cases are in men. And these are mainly men. So 20 to 29, 30 to 39 years old is the majority. When you ask about race and ethnicity, the respondents, the #1 race that the respondent tells you is Black, followed by white, and then Latino. So about monkeypox transmission. So one of the main ways that people get monkeypox is by close contact with the rash itself or body fluids that are coming from the rash. So if the rash is weeping, and obviously that could occur during intimate contact, like sexual contact, but it can also occur just during casual contact, non-intimate contact. So monkeypox is not totally equated with just sex. It could be hugging that is just, it's not sexual. MPOX can also be transmitted via contaminated materials, such as bedding, towels, clothing, anything that comes into contact with the also large respiratories. What we have seen is that most cases of MPOX are in people who identify as men having sex with men, but I do want to reiterate that anyone can get monkeypox. It is not just a disease of gay men. It's a disease that anyone can get. So it can happen in females. We are seeing a few more cases in females. The incubation period for MPOX, so the incubation period is defined as the time from when you are exposed to infectious organism to the time when symptoms first begin is broad. So it's 3 to 17 days. That's a pretty wide incubation period. Another thing is that we get asked a lot is when is a patient infectious versus not infectious? So a patient is considered infectious from the time of symptom onset, whatever that onset may be, until the skin lesions have scabbed over, those scabs have fallen off by themselves, and new skin has formed to take its place. Once this happens, then they're considered non-infectious. The virus has been detected, the monkeypox virus, in anogenital and urethral samples in people without symptoms. No cases of transmission have been linked to exposure to infected people who did not have signs or symptoms. Now that's, an early finding. We'll have to see if that remains the case, but it's looking like people have to be symptomatic in order to be transmissible. So let's talk about the clinical assessment of a patient with monkeypox. So oftentimes people with monkeypox will have a syndrome, and that could happen with any virus, not just MPOX. So they'll get typical fever, chills, headache, all the things that we associate with prodrome. And Then the rash typically happens, 1 to 3-ish days after the prodrome. The thing is that with MPOX, it doesn't always go that way. Sometimes you get a viral prodrome and then, you get the typical rash. Sometimes you may get the rash first and the viral prodrome may happen after the rash. So it is variable. Places where you typically see lesions, one is the mouth. And obviously the skin lesions, are classic, and the skin lesions progress through these kind of classically defined stages of macules, then papules, then they become vesicular, then they become pustular, and then they scab over. This is sort of classic MPOX. MPOX is typically an uncomplicated limited illness. So in the great majority of patients, it is not a serious illness, and it's not an illness that leads to a lot of mortality. However, there is morbidity that goes with it that is pretty important. The illness itself can last for 2 to 4 weeks, so it may take 2 to 4 weeks for those skin lesions to actually resolve. And lesions can be quite painful and itchy. And the thing is that the pain and the itching may really be out of proportion to the size of the skin lesion. So that's one thing in terms of, you may see a skin lesion that looks pretty benign, but it may not be as benign as it really appears to be. Now, this is one thing that has been noted, is that people who are immunocompromised for any reason, it could be AIDS or advanced HIV disease, cancer chemotherapy, really anything, they appear to be at higher risk of and more prolonged monkeypox infection. The thing that is known at this point is whether people who are immunocompromised are more likely to acquire monkeypox. That is simply just not known. So these are pictures of typical rashes, and what you can see, if you're following the mouse at the top, you've got the top 3 pictures where you see what looks like pustules. This one over here, the one that I'm circling, you can see that's got a little bit of umbilication, and that's the kind of a tip-off that sometimes MPOX rashes will do that. It will umbilicate. It's not diagnostic by any means, but it may give you a little tip-off that you're dealing with MPOX. Here you can see these rashes are starting to scab over, and then it's just a matter of waiting for them to fall off. These lesions can certainly be confused with other lesions, particularly transmitted infections, particularly if the lesions are in the genital area or anorectal area, and lesions can be there with MPOX. So distinguishing monkeypox can be difficult, because the MPOX rash can be confused with STIs, sexually transmitted infections, particularly if it's in genital or perianal area. And the other thing is that just because someone is diagnosed with an STI, like gonorrhea, that does not exclude monkeypox. People can have concurrent infections with both MPOX and an STI. So when it's time to evaluate the patient, obviously the history of illness is going to be, you want to know about was there a viral prodrome? When did the rash start? What have these lesions been like? Are they painful or itchy? That's a clue. Social history is going to be key in protecting a sexual history from the patient. Does the patient participate in anonymous sex? Does the patient participate in other kinds of high-risk sex? The physical exam, obviously looking at the rash, are the lesions in the same state of development, or are they lesions that are in different states of development? Is there any umbilication tip-off as to MPOX? Umbilication could also be seen in molluscum contagiosum. And then want to ask about some epi criteria. And so a patient who's a newer characteristic rash, they have epi criteria, and you're concerned about MPOX, you definitely want to test them. Really, the bar, I mean, to me, the bar should be relatively low in terms of testing for MPOX. So what are some of those criteria? So first, has this person, our patient, been in close contact with someone who has a rash or received a diagnosis of confirmed or probable monkeypox? This is one that is not uncommon, a close contact. What about a person what about our patient? Has our patient been in contact in basically a social network where there's sexual activity going on and there is monkeypox activity in that sexual group? So you may have essentially kind of a sexual group, a sexual club, where you're not sure if the patient has had direct contact with someone with MPOX, but you may know, the patient may tell you that yes, there is MPOX in this group. That's going to be an epi tip-off. Travel to a country with recent monkeypox cases or outbreaks. We talked about, there's been there are 100+ countries that have had cases of monkeypox. So if we have a patient that we either suspect or confirm monkeypox, we need to isolate that person. We're going to use standard and transmission-based precautions. And one of the things that we would ask is that please contact your local health district immediately. And that is for either a suspected case, one that you have not confirmed yet, but you are concerned about it, a suspected case or a confirmed case. And I will tell you, from the local health department point of view, the easiest thing is just to pick up the phone and call the local health department. That is because that way you have done your responsibility of notifying the health department. That gets the information to the health department right away. And that way the health department can start doing the things that they need to do as far as getting their center for a possible MPOX case. Now, if you want to report electronically, you can use the confidential morbidity portal. However, I'm going to put in a plug for just making a phone call, because that's the simplest way to do it. I've also put in a link to the local health department locator tool. And so you can look up to see what health department is in your city or county and just simply give them a call to let them know that you have a patient with either suspected or confirmed MPOX. And obviously you're going to test for MPOX and other illnesses, and we're going to get back to that a little bit. These are some resources as far as assessment and evaluation goes. So all of these links, these are all provide informative information. So let's talk about infection prevention. So, if we have a patient with suspected or confirmed MPOX, we've already talked about the fact of isolation. We want to isolate in a single room. This could be an office exam room. This could be a hospital room. And special air handling is not needed. Okay, so the person does not need to be in a negative pressure room. The patient should be masked. The lesion should be covered. For healthcare providers, we recommend that they and transmission-based precautions. So that would be gown, gloves, N95 respirator. If you don't have an N95 respirator, a face mask, and then eye protection. And eye protection would either be the chemistry goggles or a face shield that covers basically the entirety of the face. Basically, the reason for the face shield is that it covers the entirety of the eyes. You want to avoid any activities that may spread material from these lesions. So any soil laundry should be handled gently. You don't want to shake it, or you don't want to handle it in a way that you're going to disperse skin cells or other kinds of fluids into the air, because that's a way that could transmit infection. You also want to avoid the use of portable fans, dry dusting, sweeping, vacuuming, because again, these are just basically aerosolized skin, and they may also aerosolize a rash that is weeping. So monkeypox has been transmitted in the healthcare setting. And what has been reported is exposures through needle stick injuries, direct contacts with the specimen or a skin lesion from a patient, or aerosols generated in a lab. So again, just to reiterate, healthcare provider, gloves, gown, N95, eye protection. There is no, some of the things in really of importance I put in yellow highlights. There is no need to de-roof a skin lesion to collect a specimen. So but sometimes people do this. And there was one case written up in the MMWR of a nurse who was exposed to monkeypox because unroofed a monkeypox lesion to get, with the idea of getting a better sample. And then the nurse inadvertently stuck themselves with the needle. That nurse did acquire monkeypox. Fortunately, it was a mild case. The nurse did get post-exposure prophylaxis, but there is no need to use a needle or a blade to unroof a lesion. All you have to do is a dry swab of the lesion itself. That's going to pick up plenty of DNA. So, we've talked about this as far as isolation and prevention. CDC recommends that people with monkeypox isolate at home, another location, for the duration of the illness. So that could be 2 to 4 weeks of isolation. That's a long time. This applies to both adults and children. So this is something to take into account if you've got a patient with MPOX. More things about isolation. As far as precautions, we don't want patients to share items that have been worn or handled with other people or even animals, pets. You want to make sure that items are laundered and disinfected that have been worn or handled. Surfaces need to be disinfected. Obviously, the patient to avoid physical contact, including sex with other people. You want to avoid sharing utensils. You want to avoid our patient, we want to advise them to avoid crowds or congregate settings. And then we want to encourage our patients to wash their hands with soap and water or an alcohol hand sanitizer often, especially after direct sedation touches the rash. Other things that we have to be concerned about and care for at home. So what about, surfaces at home that are touched? How do we disinfect them? EPA has a list called List Q, and List Q is a list of a claim for special pathogens. And so this is the list of items that should for disinfection. We want patients to avoid the use of lenses of the possibility of inadvertent eye infection. With regard to bathroom usage, if possible, we would like the patient to use a separate bathroom. If it's not possible, then we want the patient to be very vigilant about cleaning and disinfecting. Sink, faucets, toilet seats, go back to queue as far as cleanse that we can use. You definitely want to try to limit contamination within the household. And one of the things that is talked about is, for things like upholstered furniture, if you can cover that upholstered furniture with some kind of a tarp or something, or a mattress cover or a blanket or something, because if you get MPOX, if MPOX lesions come into contact with upholstered furniture, it can be very difficult to clean them to really really feel like you've gotten the fluid from a vesicle or something like that. So if you can cover something, that's a good way to go. So these are resource and control, and links are here. So let's talk about tests for MPOX. So labs for MPOX testing that you all, I'm sure everybody knows about: Aegis, LabCorp, Mayo, Sonic. I encourage, if you're testing, I encourage you to read the lab description of what the lab is looking. Typically, what they're all looking for is basically just a dry swab of skin lesion. Some little variations on that theme as far as what they want. So please take a look at the lab ordering. DCLS with a public health lab, is not a, it's a lab for outbreaks and other things. So, DCLS, it doesn't really is a commercial lab. If you've got an MPOX outbreak, then DCLS is going to get involved, as will, the health department. Department will get involved anyway, because monkeypox is a. The point is that if you use DCL, you need to have by the local health department. So if you want to if you're thinking about using DCLS, please give health department a call. Now, this is very important, that patients who are suspected of having M or who have this really need tested for HIV. There is such concordance, 1% of people who have comorbid HIV and MPOX. You also want for other STDs such as gonorrhea, syphilis, herpes, chlamydia, and then anything else that you feel the patient needs to be tested for. That could be Hep C, that could be Hep B, whatever you want to test the patient for. But it is one that is key to test for. We've already talked about PE. You want to collect material from the surface of the lesion or the crust from a healing. There's plenty of DNA there. Typically, you want to collect a couple of swabs from each lesion. 2 or 3 lesions should be plenty of material from. Now, I will tell you, some patients with MPOX have 1 lesion, and that's it. It's overlooked. You want to use swabs. You don't want to use cotton. You swab the surface of the lesion vigorously to collect adequate DNA. We've talked about no need to de-roof or lance anything before swabbing, and you put each to a separate container. Again, all of the labs are going to have some variation on this general theme. So what if a patient tests positive? So if you get a positive test from the lab, so from one of those 5 labs, that is an actionable result. There is no need to send it to CDC. An actionable result, that patient has MPOX. Obviously, hopefully you've already reported your suspicious case to the local department, but if you haven't done that already, please go ahead and do so. You want to evaluate the patient for treatment. We're going to get to that. Now, we've got a number of things that need to be done at this point. So, things on account patient. One is to notify close contacts. One is to stay home. I stay home except for emergencies or medical care. Stay away from others in the home, including pets. We've talked about no contact with others, including sex. Wear a mask if they are living with other people. Don't share items that could be contaminated. Don't use contact lenses. Hands off in water if you don't have soap and water and alcohol sanitizer. I will tell you that the health department can be very helpful with these things, particularly with notifying contacts. The health department can help you with that. So please go ahead and get them involved early. So these are resources for testing. That some of these specimens are good to watch. So what about vaccination? So, we have 2 available vaccines for preventing smallpox. in reality, we're really using one, and that is this one, Jynneos. We're not really only in 2000 for just a second. ACAM 2000 is a replication competent live virus vaccine. So for those of us who have had smallpox vaccination with the bifurcated needle in the past, this is ACAM 2000. This is a newer version of the old Dryvax. We are not using, and I'm not sure that in the US is using ACAM 2000. Are using is Jynneos. Jynneos is a replication deficient attenuated vaccinia virus. So we're taking advantage of cross immunity because vaccinia virus is in the same family of pox viruses as monkeypox is. Now, originally, FDA approved Jynneos in 2019 for smallpox, monkeypox for adults, so people 18 years or older. But because of the current situation with MPOX, FDA has given us the use authorization. And that'll to do a couple of things. Number one, it allows us to immunize people less than 18 for children. So that's the first thing. The other thing that we can do that you probably already know about is, the vaccine is given as a subcutaneous injection. That's how it's FDA approved. But the emergency use authorization, what it does is it allows for intradermal injection. And this is exactly, and what that does is when you use the intradermal injection, you're only using 1/5 of the amount of juice. This was done to make basically the vaccine that we have last longer. So instead of one vial being one dose of a vaccine, one became 3 doses or 4 doses, or in some cases, even 5 doses, because, we could give dermally a lower dose. And if you're looking at this with the intradermal injection, this is exactly the way that you would give a tuberculin skin test. So if you are familiar with giving tuberculin skin tests, that's exactly how you give intradermal Jynneos. This is a 2-dose. The second vaccine is given 1 month after the first one. People are considered vaccinated 2 weeks after the second dose. One question that has come up is, what about vaccinating healthcare workers? Do healthcare workers need to be vaccinated against MPOX? Really, the answer, no. CDC does not feel that everybody who's a healthcare worker needs to be vaccinated. There is one contraindication to Jynneos, which is if you've a history of a severe allergic reaction to a prior dose. There are some precautions. This is made with a little bit of mycin and a little bit of Cipro. It is made with a little bit of chicken and egg protein. So if you've got people that have really severe allergies, and it really does need to be severe allergies to these things, then you probably would want to consider not using Jynneos. The nice thing about Jynneos, because it is, attenuated vaccine, it is safe for most immunocompromised people. So that would be people, with AIDS, cancer, chemotherapy, or other reasons why they would be immunocompromised. This goes into detail, and I won't go into all this, about the Jynneos emergency use authorization that we got from FDA. We've already the fact that it can be given as an intradermal dose. That is the preferred route for an adult. There are some exceptions to giving it intradermally. I'll let you read that on your own. For children, they receive the subcutaneous injection, is the entire 0.5 vial. Use some information about the intradermal or ID administration. Basically, this is the same way you would do a skin test. Actually, CDC has got a nice video of how to give the Jynneos seen intradermally. This is it's helpful. So vaccine effectiveness. Well, this is question mark. Jynneos is, Jynneos use. We don't know a whole lot about the vaccine effectiveness. We have a little bit of data. There is a preprint from Israel that effectiveness was estimated at about 80%. This study did that a single dose of vaccine was associated with a significantly lower risk for MPOX infection in high-risk individuals. However, there was another study that was in Nature Medicine to 2 doses of the vaccine in people who had not been previously vaccinated for smallpox. So now a third vaccine did significantly boost their antibody response. So this is a little known territory. Another thing we don't know is we do not know the duration of protection of Jynneos to MPOX, or if that protection wanes over time. And as you can imagine, CDC is working with partners to collect this data, which is pretty important data. So the way we use, Jynneos can be broken down into several different categories. Now, if you go to the website, you won't see these categories anymore, but I think they present a useful construct, and that's why I've kept them on this slide in terms of thinking about how do we use this vaccine. So we can use this vaccine for traditional exposure prophylaxis. So the goal is to vaccinate someone following a known exposure to monkeypox to help prevent the illness or minimize illness severity. Jynneos works best when it's given quickly after the exposure. And ideally, we want to get Jynneos into the person within 4 days after the exposure. Now, that's fast because that gives us the best chance to prevent the person from developing MPOX. If we give Jynneos between 4 and 14 days after exposure, it may reduce but not prevent MPOX. So both of these are not certainties, but they do have a chance of working. So, when coupled with self-isolation and other prevention measures, post-exposure prophylaxis is important for preventing further transmission of monkeypox. Now, one thing that is important to note, if you have a patient who has already been diagnosed, confirmed with MPOX, post-exposure prophylaxis is not indicated. In fact, if you have a person with confirmed MPOX, vaccination with Jynneos altogether is not indicated. The reason is that CDC feels that MPOX itself will produce durable immunity. So if you've got that, so for example, when would this situation come up? So let's say we had a patient who had an exposure. Let's say we gave them Jynneos within 4 days. Let's say that patient goes on to develop monkeypox. Okay, the question is, does that patient need the second dose of vaccine? And the answer is no. So there is no indication for that second dose. Now, CDC also came up with another group called expanded PEP or PEP++. And the goal here was to vaccinate people with certain risk factors who are more likely to have had an exposure to MPOX, even though they may not know that they had a definite exposure. This one, the example that I would use is sort of like the sex club example. So if you have a person who is part of a sex club, but they don't know if they have had a direct exposure to MPOX. But what they do know is that they're part of this group, and they know that other people in the group, that MPOX is circulating in the group. That puts them, that is this group. That's the expanded PEP or PEP++. And so in Virginia, again, this terminology is not used anymore, but again, I like the way it kind of breaks down because I think it makes a little bit more sense. In Virginia, the recommended groups are people of any sexual orientation or gender who have had anonymous or multiple sexual partners in the last 2 weeks. So if you have that history, that is enough to get JNAO, because that's considered a high-risk behavior. So people of any sexual orientation diagnosed with any sexually transmitted infection in the past. So this is going to cover a lot of people right here. So if you've had an STI, if your patient's had an STI within the past 3 months, they are going to be eligible for JNAOs in Virginia. A person who has HIV or AIDS, that is going to be that they should get vaccinated with JNAOs. Staff at establishments or events where sexual activity occurs. Sex workers of any sexual orientation or gender. And the thing is that in Virginia, the JNAOs vaccine really is primarily available at health departments. It is free of charge. And one thing is that people do not have to identify which group they fall into. All they have to do is just to notify the health department people that they do fall into one of these groups if they're getting it for expanded PEP. One thing I did want to point out is that people living with HIV or other immune compromising conditions, like we talked about, may be at higher risk for severe MPOX outcomes, and therefore they should be high priority for vaccination. And then the last group for JNAOs use is exposure prophylaxis. So this is just everyday vaccination. This is why we vaccinate people against, measles, mumps, rubella, everything else. And, the goal is just to vaccinate people. Right now, the goal is to vaccinate people whose jobs might expose them to orthopox viruses such as MPOX. So like we talked about before, at this time, CDC is not recommending that most clinicians and laboratorians get vaccinated. They don't feel that that is needed. However, what CDC does say is that the following groups might be eligible to get JNAOs. So if you are a clinical lab person and you perform orthopox virus testing specifically, including PCR assays, you would be considered to get JNAOs. If you are a research lab worker who directly handles cultures or animals contaminated or infected with orthopox viruses that infect humans, again, another consideration for giving JNAOs. And this category here, certain designated healthcare and public health response team members for preparedness purposes. So, if you are an infectious disease physician and you are going to be seeing, MPOX patients, then, essentially, you may fall into this category of, that you're somebody who would come into contact with MPOX. Or if you are someone who's going to administer ACAM 2000, if you are in this group, it is recommended that you get JNAOs vaccinated. Now, one of the things at VDH is we are always looking for medical providers who would like to administer JNAOs vaccine. I won't know the details of this slide, but these are the things that you have to do if you administer JNAOs. We are happy to help you with this process. I'm putting a plug in for VDH, I know that, but we certainly would like to get more JNAOs vaccinators. As you can see, there are lots and lots of resources regarding the JNAOs vaccine, and so these are listed here. And so the last section is monkeypox treatment and patient management. So like we talked about, most people with MPOX have a mild self-limited illness and it goes away on its own. They do not need any specific drugs for MPOX. the thing is, right now, we do not have any treatment specifically approved for MPOX virus infections. However, we can use some antiviral drugs for smallpox that may be beneficial. Now, who would we want to think about treating with drugs? First, if you have severe disease. So if you have hemorrhagic disease, if you have confluent lesions. So for instance, if you have a situation that's almost like a burn, essentially, where these lesions are coalescing together, that's a reason for treatment. Obviously, if you have MPOX that is affecting other organs, so you're septic, you have encephalitis, you have an eye infection, other things that have put you in the hospital, definitely treatment needs to be talked about. If you have involvement of an anatomic area that might result in serious morbidity, you need to think about treatment. I will tell you that one of the things about MPOX is the sequelae of an MPOX lesion may be scarring or stricture formation. And there are a lot of places where you definitely would not want that to happen. So, for example, if you have lesions, MPOX lesions of the pharynx, the penile foreskin, vulva, vagina, urethra, rectum, you don't want strictures or scarring in any of these areas because that's going to negatively impact the patient. This is another situation where you definitely want to think about treatment, and it really should be thought about early. If you are at high risk of severe disease, let's say you're immunocompromised from any cause, whether that's HIV, AIDS, cancer, chemotherapy, other drugs that might knock down the immune system, you're pregnant. Again, treatment needs to be talked about. And the other thing about treatment is you should think about it earlier rather than later. So tecovirimat, or the brand name Teapots, is the preferred antiviral treatment at this time. Now, tecovirimat is available through the Strategic National Stockpile under an expanded access investigational new drug protocol. So here's tecovirimat. It is usually given as an oral medication. A typical course of tecovirimat or Teapots would be weeks, but it can be given for longer periods of time if needed. Teapots also does come as an IV solution. This is not used that often. So this is our main drug. Now, there are other drugs, cidofovir, Vaccinia, immune globulin intravenous, and the most recent brincidofovir. These are other drugs that can be used. I'm not going to go into detail about these because if you're talking about treatment, this is really the main one. When you're talking about these drugs, really you need to get an infectious disease specialist involved or talk to CDC. So I want to talk a little bit about Teapots. So Teapots is FDA approved for the treatment of smallpox, not monkeypox, in adults and children. Unfortunately, we do not have good data on the effectiveness of Teapots when it comes to treating MPOX in humans. And we do have a trial that is underway to study this. So far, in terms of people that have used Teapots, we have not seen any really bad side effects or safety signals. You can see that common adverse reactions are listed here. The nice thing about Teapots is that it doesn't really have a lot of drug-drug interactions that are problematic. So there are a couple that are listed, but these are generally probably not a problem. So if you want to get Teapots for your patient, you have to go through the process because it is an investigational product. So, there is some paperwork. Again, the health department can help you with this. Another want to do with VDAs, we want to encourage people to become more familiar with Teapots. And so that's where we can help with this. But these are to get Teapots. This is the STOMP trial. The STOMP trial is the tecovirimat for human monkeypox virus. It's funded by NIAID. It's a clinical trial to evaluate the effectiveness and safety of in human MPOX. The aim is to enroll more than 500 people from about 80 clinical sites in the US. There is an open label arm with this. Patients with severe disease or those at risk for it will all get Teapots. And I will tell you that what we're hearing right now from CDC is that if people, like let's say you have a patient with MPOX who you want to get Teapots for, really what CDC is saying is try to enroll them in the STOMP trial, because that way they can get Teapots. There is another arm of people who are randomly assigned to receive Teapots or placebo for 2 weeks. And then link down here to this. So the final few slides, guidance and supportive care. You obviously want to educate patients about the course of the illness. And we talked about the fact that most cases are mild and self-limited. Things that you want to do as far as supportive care, fluid balance, pain management, which can be a big deal. If you have bacterial superinfections, those need to be treated. You certainly want to look for any coexisting STDs and treat them if they're there. And the thing is that supportive care may get complicated and may require hospitalization in patients who have dehydration, severe pain, be controlled at home, or patient develops complications, and that happens. I won't go over all the stuff with pain management. You can try, pain control with over-the-counter meds. You can try topical steroids and anesthetics such as lidocaine. Just be careful that topical lidocaine can be absorbed systemically through a wound. You can try short courses of analgesics such as gabapentin or opioids. That's fine. And appropriate pain control may not be able to be achieved at home with pill medication, may require hospitalization. As far as the rash and skin lesions, these things can itch. These things can be quite problematic. So for pruritus, typical things, topical agents, oral antihistamines. For oropharyngeal lesions, magic mouthwash, saltwater gargles. Genital and anorectal lesions can be quite a problem for the patient. Sitz baths, pain medication are things that you want to think about. And these are treatment resources for MPOX. And one thing I definitely want to point out is CDC has a clinician consultation line that is open 24/7, and they will take your questions about anything having to do with monkeypox, whether it's diagnosis, testing, treatment, ongoing patient management. So they can help you out, and they will help you. This is the CDC number. It is available 24/7, and CDC has mentioned on multiple calls that they would like to hear from clinicians. So please feel free to use this. I wanted to go over one last thing, and this is something that Dr. Hanakowitz showed me. This is out of France, where they looked at 276 participants who had an MPOX exposure and were given Jynneos as post-exposure prophylaxis. And they were the median time that they were vaccinated was 11 days after their exposure. What you can see in this little study is that only 4% of people developed monkeypox. 96% of people did. That is great. Now I've put, so this is certainly interesting data. Unfortunately, there is no control group, so it's a little hard to evaluate this data just by itself. One thing that was noted in this study is that 114 of the participants did have multiple overlapping MPOX exposures. There were no serious adverse events with Jynneos provided against MPOX. The external validity, the generalizability of this study is kind of uncertain. This was done at one center in France. So, we have a limited number of observations, but I think this is encouraging data. Thank you for your attention. I know this is a lot of material, and I'm happy to take your questions.
Thank you very much, Dr. Rossheim. I don't know, Dr. McIntosh has a question. I don't know if she's able to answer, present this, or whether I need to read it.
Oh, I either way, I can see the question.
Okay, so I'm just gonna, for the audience then, as a Dr. McIntosh, as an internal medicine hospitalist physician, I'm very proactive on testing my patients for other STIs, including HIV as well. Do you recommend initiating treatment for newly diagnosed HIV infection concurrently with treatment for MPOX whilst hospitalized? Thank you.
Yeah, the thing is, as soon as you can initiate antiretroviral therapy, you want to initiate it, because that will help the patient's immune system, and that will likely get the patient's monkeypox under better control. So as soon as you're able to start ART, then yes, you want to go ahead and start it.
Right, very good. So that means that you would immunize patients against MPOX when they were newly diagnosed with HIV, is Brooke, or is that?
No, you're not. No, if a patient already has, if a patient is already been diagnosed with MPOX, there's no indication for vaccination. But if a patient, for instance, has a new diagnosis, when you're evaluating them for their monkeypox, if they are found to have, untreated HIV, then you want to start them on treatment for their HIV as soon as possible, because that will help to get their, to knock down HIV, which is going to be better for their immune system and therefore better for, getting monkeypox under control. Does that make sense?
Right. So, but those patients who are HIV positive, they are eligible to get the Jynneos vaccine, correct?
They are, as long as they have not. This is a little bit debatable. If they've already had monkeypox, that's kind of debatable about whether they should get vaccinated with Jynneos. If they had monkeypox, then yes.
Right. Okay. Thank you. Any other questions? I think this is very comprehensive, Dr. Rossheim. I mean, it really answered a lot of questions that I might have had as well. What do you think about the practicality of testing for everyone who's had an STI in the last 3 months? That's a whole lot of people.
Well, you don't, that in those people an STI within the past 3 months, you don't necessarily have to test them for MPOX. Those people would be on the list to get expanded, PEP. Those people would fall in that category who could get Jynneos. Now, if you feel like you want to test those people, for MPOX, that is fine. But those people are on that list for, PEP plus, that expanded PEP.
Right. So there's a lot of people, but
that is. And what I would tell you is that what you've seen over time is that, the bar, and really this was a function of Jynneos that was out there. The bar for getting Jynneos initially was kind of way up here. You had to have a lot of risk factors and a lot of epi criteria to get Jynneos. And what's happened is the bar has steadily come down as the supply of Jynneos has gotten better, as we've done more of the intradermal injections, which gives a vaccine. What you've seen is now the criteria have eased up in terms of eligible for Jynneos.
Thank you. We're getting towards the top of the hour, as they say, and I don't see any other questions. So I think we can stop here. Dr. Rossheim, thank you so much for your lending your expertise here, and hopefully the bar will stay low. And I'm fascinated by all the measures that you do that just related to what you would have done for smallpox, of which of course we have luckily no experience with. So, but it's quite the same. At any rate, thank you very much, Dr. Rossheim, and thank you to the Virginia Department of Health for all the good work.
For having made it.
All righty. All right. Very good, Brooke.
Okay.
Take care. Bye-bye.
Okay. Bye.